So we are all aware that rheumatic heart disease still happens. Dr. Prasanna Sinha was very eloquent in the morning, telling us about how there are differences between Bengaluru urban and Bengaluru rural. What we do not realize, and I think I've discussed this with Dr. Hiramat, who's here, is that the sub-Saharan Africa and in the Indian subcontinent particularly, it doesn't take 25 years for the manifestation of chronic valvular effects of rheumatic heart disease. So we will, in our practice, and before we go any further, I practice in a tier 2 city. And one more disclaimer, I'm the last cardiac presenter for the day. So I am the least in the wine bottle, you see. Everything is gone. Gone are the Ozakis, gone are the repairs, gone are these fancy procedures. I'm going to talk about good old-fashioned mechanical valves. So rheumatic heart disease contributes a large amount. It's still more than 50% of the pathology I see in young children who come to me. The smallest and the youngest rheumatic I've replaced is 5 years old. A lot of congenital valvular pathology also occurs. And in this, forget the mitral valvular lesion, we will have what is dreaded, parachute mitral valve. Then we will have dilatations of the annuli, or maybe cardiomyopathy, or maybe Marfan's borderline. Dr. Chaudhary might disagree with me, but at about the age of 13 or 14, you have a good chance of getting one of the Marfanoids to have a repair to do. Similarly, a bicuspid aortic valve. Aortic stenosis by far is the commonest congenital heart condition which presents. And a bicuspid aortic valve with perhaps not as fancy as a post-stenotic root dilatation requiring Bengtal, but yes, small aortic roots and bicuspid aortic valves. Forget about, I'm not really truly, dyed in the wool pediatric heart surgeon. So let's forget about hypoplastic left heart. Interestingly enough, most rheumatic pathologies which will require either aortic or mitral, which will require valvular intervention, are generally regurgitant in kind. So if nature decides to give us a rheumatic pathology to operate at young age, nature also decides to perhaps give us either pure regurgitant lesions or regurgitant with stenosis, mixed lesions. So maybe the annulus is not as much of a concern there. This slide, everybody will show, and people will wax eloquent about various kinds of valves, homographs, Ozakis. It doesn't exist. There is no ideal prosthesis known to man, whether it be mechanical, whether it be bioprosthesis, or whether it be anything else. This again is going to be very funny. Remember at the start of my talk, I said we are going to restrict our talk to children less than 14 years of age. These are small patients. Not all of us, at least my setup, we don't have a transesophageal which will work in children less than 20 kilos of age. 15 or 17 is what we will go. I'm sure there are institutes where they have small infants and neonates also perhaps get transesophageal. You read up reports 1.4, 1.5, small things, which if the probe goes here and there, it affects the lie of the endotracheal tube. That's what we're talking about. Interestingly enough, before all these diagnostic modalities came up, I don't know how many of us remember the good old double dilution technique. So there was a double dilution technique in which you went transeptally into the LV, injected dye, and took samples from the left atrium and the aorta, plotted a computer curve, and calculated your regurgitation. This was before the echo. I happen to have used it and seen it. I am that old. Dr. Iyer presented a paper somewhere, actually wrote a paper in a pediatric journal where he stressed upon epicardial echoes. Again, I am not familiar with, I would appreciate the audience telling me if they are using epicardial echoes as a tool to diagnose. There you see, Dr. Prasanna's hand goes up. As an epicardial echo as a tool to diagnose valvular lesions in pediatric population. We'll skip this. I am also going to not talk about this. This has been extensively covered, and this is not my brief for the day. But with one caveat, if you are good enough, if you can get away with repair, please do it. Even in young children, do not consider valve replacement as the first modality of choice. That's the only reason why I bring up this slide here. And these two papers, interestingly enough, I'm quoting, are from Scandinavia. One goes on to say that pediatric mitral valve repair can be performed with low initial mortality, but should be reserved, and mind you, these are important words, should be reserved for medical and reconstruction failure. Bileaflet prosthesis larger than 23 millimeters. How many of us actually wind up putting a 25 bioprosthesis in metallic prosthesis, mechanical valve in many of our young female patients? So anything more than 23 in their hands in West requires less chances of reoperation. There are reports of a 16 valve turned upside down, a 17 valve turned upside down, i.e. the aortic valve mechanical being used in the mitral position, which is what the second paper from Scandinavia says. But you know, we are really scratching. These are patients I would wish upon my enemy. I would not keep them myself. I would wish upon my enemy. But if you're pushed, if push comes to shove and you have to operate. Another interesting technique, and again, feedback from all these learned audience is appreciated. Another interesting technique is to perhaps place the valve way up in the left atrium in the hope that you can get a bigger size mechanical valve in these small children. Again, Dr. Shiv Chaudhary took you through an entire EOA and whole stuff. So an ideal aortic valve must result in an unobstructed competent aortic valve, which is also durable and accommodates the growth of the child. Doesn't happen. In real life, doesn't happen. Again, you get a very small child with aortic stenosis. For God's sake, send him to a pediatric cardiologist with some structural experience who will dilate him, give him minimal aortic regurgitation, let him grow a bit before you start attempting any aortic valve surgery is my mantra of choice. I would be really drag kicking and screaming to do small children. Again, pretty much the same. If you can repair, please repair. If you can do an Ozaki, yes, sure. One of my junior partners is very interested, and I'm sure he will one of these days find himself in Bengaluru in one of these Ozaki workshops, and maybe we will do some Ozakis before we even think of replacing them. Interestingly enough, Ross in a juvenile rheumatic, Dr. Sampath's articles from the All India Institute tell us that it doesn't work. Ross in juvenile rheumatics doesn't work. So you're then pushed to, maybe a mechanical valve with root widening. I'm going to come to that. On an aside, in an aside way, we talk a lot about these choices, but how many of us are aware that Arnold Schwarzenegger has had 3 aortic valve surgeries? First Ross, then a replacement of the pulmonary part, and now finally both the pulmonary and the aortic replaced. The smallest size mechanical prosthesis available for use in children is 16 millimeters. There was a talk of Nick Manoogian and Kono. Tissue prosthesis, I think I saw a slide which said 17 is available, but only on specific prescription, that I cannot put anything less than 17. Homograft and Ross, yes. We are going to extrapolate what happens to congenital heart disease, left to right shunts and VSDs and tetralogies, and take them over to our patient population, which requires valvular surgery. Once you repair valves, growth recovery is excellent. If they are indicated to have a valve surgery early in their life, and you give them a good, competent or replaced valve or a competent repair, whatever delay of their secondary sexual characters has occurred, it takes up. There is a paper which quotes long-term survival after aortic valve replacement in juvenile population, 81% at 10 years. The aortic atrioventricular valves, surprisingly, do not do very well. And the same paper which quotes aortic atrioventricular valve goes on to say that if you place the atrioventricular valve in the left atrium, slightly higher than the annulus, it actually produces more complications than if you put it in the annulus. So these days, they are again talking about children with aortic pathology, and then they are talking about how planning, and this slide has been shared at least by 2 authors. Planning, how do you go? You go about with the Ross, and then maybe then move to a mechanical, then move to a tissue, and then maybe a valve in valve. This shall be the bane of my talk if we are recommending mechanical valves in children. How do you anticoagulate them? Can you imagine telling an 8-year-old boy in this country, don't play cricket? वो cricket की ball सर पे लग जाएगी, warfarin खाता है, bleeding होगी. Try doing that. It doesn't work. Till about 6 years ago, the lowest warfarin or acenocumarol dose you had was 1 milligram. 0.5 would not come. And the same fellow, dawai wala, would sit in front of you and say, sir, dawai aadhi nahi karna hai, uski bioavailability ki koi bharosa nahi rehta hai. So you could not, lower dose. Now 0.5 is available. We just saw a slide. How many of them are NABL recognized? How many of them understand the true value of INR? I mean, I'm here speaking on mechanical valves, yet I'm condemning this. And I tell you, and I think I will have the house on my side if I say that the operative mortality in valvular surgery, the leading cause is oral anticoagulation. We don't kill as many patients with our operative procedures as warfarin does. And then the reason, as I said, why we are here is because I just, that was last annual conference and I presented 150. The number has since then gone up to 185. And we've kept this cutoff age as 14. The commonest pathology is rheumatic. And in rheumatic also, we've been very lucky to replace pure rheumatic stenosis. We will try and get away with OMV and some form of repair. So if it is rheumatic and most likely mitral because of regurgitation, we have been very lucky to escape with a size of 25. I have put a 25 millimeter mechanical in a 5-year-old child and gotten away with it. At least so far, till warfarin gets him. We have had a couple of cases where aortic repairs failed after a VSD. VSD closure and the aortic repair failed. And we took them back and put in a mechanical valve this day and age. And as I said out in my earlier part of my presentation, if yes, there was one of us who learned Ozaki, and maybe I will, I'm sure Vinayak is going to roast me over the coals. Why can't you go and learn Ozaki? So if one of us does, then maybe there was a talk of monocusp Ozaki or bicusp Ozaki, and then maybe we will just get away without replacing aortic valves in this patient, in whom actually VSD is not very big, but it's that venturi which is sucking that leaflet and is causing more of a damage. We also take, we are in a tier 2 city, we take all takers. So we've had Epsteins come up to us. And I've repaired a couple. I worked with Gordon Danielson for 6 months. So I repaired a couple, but these days our choice is actually replacement. And we've had a horrible experience with bioprosthesis, which was Gordon's favorite choice of valve in the Epstein. If he had to replace was bioprosthesis. We've had a bad experience with bioprosthesis, young females, it degenerates fast. So we've put in mechanical valves and gotten away with it. We have done only about 12 aortic root enlargements between the non-coronary and the left coronary cusp going down. The only difference I have with Dr. Chaudhary is that I'm using native pericardium in a teardrop fashion. I do not use a diaphragm, but I do not know about that. And forgive me for this. About 10 years ago, I went to the local Council for Science and Technology, very perturbed with the fact that warfarin was killing my younger patients. And I asked for funds, and I got a fund. Initial fund granted was 15 lakh le jaiye, Doctor Sahab. So I got a fund. And we proposed a trial wherein we would have 2 arms. All patients who required mechanic valve replacement in population less than 14 with small left atria and in sinus rhythm would be assigned either to a bioprosthesis or a mechanical valve. And believe me, I failed to recruit patients. The exact reason was that when you start as a part of informed consent, sitting down and telling them कि ये valve है, इसमें आपको खून पतला करने की गोली खानी पड़ेगी, जांच करानी पड़ेगी, और हो सकता है 10 साल बाद आपको ऑपरेशन कराना पड़े. ये valve है, ये valve कुछ नहीं करना पड़ेगा, लेकिन 10-15 साल बाद ऑपरेशन करना पड़ेगा. Finished. And as I said, we are not talking to very well-learned and well-educated patients. So, this is the reason why we are talking of mechanical valves in the young. The trial failed to recruit patients. I had to return the money back. I have failed to recruit patients. So my conclusion is that smaller size valves in mitral position are a feasible option. Some centers have reported supraannular placements of mitral valve as a long-term incremental risk factors. Small size aortic valves are an option. The smallest is 16. We are actually following 2 patients of 16 who come every 3 months, get a serial echo done. And one of these days, I'm sure I'm going to have to reoperate on them, but so far haven't had to, and I'm not rushing into reoperations. Increasing the size of the aortic root is one of the easiest techniques which all of us who practice valvular surgery should learn. Aortic root enlargement is this is stupid and I apologize again. Increasing the aortic root size is the easiest technique and it's widely reproducible and we should learn this. The anticoagulation continues to be a challenge. None of the newer oral anticoagulants will ever work. And regular follow-up of these pediatric patients and actually getting them back for redo. The risk for redo actually is minimized when you get them in an optimal position with the ventricle still preserved. If you get them when their ventricle has started going down the hill for redo, your results will also go down the hill. So a regular follow-up with an impression. And yes, for God's sake, I think all of us as surgeons need to take away this impression out of our head that mechanical valves are a one-time option. They are not. These valves will have pannus, these valves will get stuck, these valves will do all sorts of circuits. But having said that, in a smaller center, if you are going to deal with some rheumatics, some congenitals, less than 14 years, consider mechanical valves as a valve of choice. Thank you.